All right.
All right, welcome to ORTHOSTATIC, a podcast created by the Academy of Orthopedic Physical Therapy. Keelan Enseki is on the show today. Keelan, welcome to the program.
Thanks, appreciate it. Thanks for having me.
What's your background? You've done a bunch of different things in your career. What do you get to do? I'm not going to say what do you have to do. I'm going to say what do you get to do now in your PT career?
Yeah, it's kind of a mixed role that kind of has evolved over time. First and foremost, I still get to treat patients, which is great. It's something I would never want to fully leave behind. It may not be as much as I used to, but I still see patients almost not exclusively, but probably 90% with hip-related pathologies of different types, non-surgical, post-surgical. I'm the administrator for our residency programs. We have 5 within UPMC, and day-to-day, I'm in charge of the orthopedic program, and have a little bit of a role with our clinical innovation, which is everything from telehealth to some of the things that are coming down the pipe, particularly in orthopedics and sports medicine, physical therapy. And then also a role, I still am an adjunct faculty at the University of Pittsburgh. And for the most part, for the residential DPT program, I teach most of the hip-related content.
All right. So you're the guy. You're the guy for this. This is right down the middle. This is your wheelhouse. We're talking about navigating orthopedic surgery recovery, something you're clearly familiar to. I wanted the audience to know that. So let's talk about big picture key factors in successful post-surgical recovery in orthopedics. And this can be anything from clinical to education to communication. If someone were to say, what are these key factors? How would you answer?
You said one of them, communication. And that's communication with the therapist, the physical therapist, the surgeon, the patient care team members. It's just crucial we understand on our side, from the therapist perspective, what procedure is performed, because not all the procedures are the same. They're categorically maybe similar, but there are variations that could greatly affect the rehabilitation. Communication between us, the patient, it's crucial we monitor their response, not only for things that maybe are signs of things not going the right way, but also we use that response as some of our criteria to progress people through the rehabilitation protocols.
Right.
Along with that, compliance. I think we all know that, right? But when we say compliance, it's not just consistency that they're doing things, but the quality of which they're doing things as well. It's not always time, that is part of it, but it's also, are they doing things correctly, the right order, etc. And we're the primary drivers of that, other than the patient themselves.
Sure. And is there a third that you might throw in there on top of communication and compliance?
Yeah, and they probably fall within that kind of a subdomains of it, but that's constant reevaluation and review of goals. So reevaluation, how are they doing objectively? Are they following the expected trajectory, which there's variation there, but also review of goals. Are we meeting that patient's goals within what is expected at that point? And sometimes that's really in the back end and to let them know your goal is great, but is it realistic for where you are in the rehabilitation process? And that can be a challenging conversation at times.
Right. But a conversation that should be had, and the earlier I imagine you have it, the better that understanding has a chance of being achieved.
Earlier and often. Correct.
All right. So your very first C, and I don't think we even planned on that, but that was 3 C's, right? We had
communication,
and compliance. So how do PTs collaborate with surgeons? Because now you're mentioning, in terms of communication, all the different people in our neighborhood or on the rehab team, right? Mm-hmm. How do PTs collaborate, or how do you suggest they collaborate well with surgeons to ensure optimal recovery outcomes?
Yeah, and that can be a challenge. I'm fortunate in our system. We're an academic medical system. A lot of the surgeons that I work with are down the hall, or I happen to know them. I've been doing this for a while. But irregardless, that open line of communication, and really, I look at us. Our role is so valuable in communication because we are the primary and most frequent touch points for the patient, for us to advocate what is going on with the patient to the surgeon. So frequent communication. You do have to get to the point at times. They're very busy. So you have to speak their language, give it to them in summary fashion, kind of really put an emphasis on the important points of what is going on. So the other part of that is we, over time, particularly as we've been kind of shifting to an emphasis on milestones, in rehabilitation, we help develop those milestones. I mean, that's what we do. We look at how an individual is moving and the quality of their movement and where they are in these goals, and we're the experts there. So taking that and being able to communicate with the surgeon, how we can integrate that into the protocols for progression, we play a valuable. We are the primary drivers of that part of the process. And again, I think consistency when we communicate with our surgeons, and speaking their language is invaluable.
Yeah, understand those things. So let's talk about things that are common, right? Frequently asked questions is one thing, but what about common challenges that you see patients facing after an orthopedic surgery? Doesn't really matter what it necessarily is, but what comes to top of mind when we talk about common challenges?
Yeah, and it actually, there are two things where we talked about that kind of fall in there, and then they're part of a kind of the bigger picture. And when we talk about compliance and goal management, sometimes the long game is the challenge, right? Because some of these surgeries, most of these surgeries, have some component of time that is involved, even if they're doing perfectly fine, and they're the textbook case that you want to see. And the challenges often are getting the patient to invest in their own success, right? And not trying to rush the process, but also not giving up at some point and saying, hey, this is where I'm at. You want to be realistic, but at the same time, the constant reinforcement of where they are, bringing in reality, and having those discussions very often, because it is hard. Patients either check out or they'll just jump ahead of you at times. And both of those kind of fall under compliance and goal management as well.
Yeah. We want things to be personalized. You mentioned not skipping ahead, not lagging behind or checking out completely. What are some tips or suggestions you give to colleagues or students if you're interacting with them in terms of having that recovery protocol developed, but also personalized for this person? So when we say personalized, we might have similar surgeries, but not everything is the same. And we're similar humans, but not everything's the same. So what are suggestions to really develop a protocol and personalize it to that person's recovery?
Yeah, it's interesting because you're always trying to, which can be somewhat it is clinical and feel very clinical when you look at best practices, hierarchy of evidence, all the things that we consider that must be considered with a rehabilitation protocol. But at the same time, that matters to the patient. But what really matters are their goals. So really keeping this somewhat clinical approach, very clinical approach, delivered in a patient-centered fashion. So what I attempt to do, and there's challenges with this at times, is to anything that we're recommending and bringing back to a goal that they have. Maybe it's a short-term objective to get them to where they want to be tomorrow, reducing pain, allowing more range of motion, or bringing that back to the long-term goals of, let's say return to sport or return to just any daily activity, playing with their grandchildren, anything like that. Anytime we can bring back what we are delivering in a clinical fashion and is appropriate to in a patient-centered fashion to address a goal or an objective, I think that's how we keep it personalized. And sometimes those goals change for the patient. And if that changes, we have to incorporate that into our plan of care when we're looking at, again, that long game.
Yep. Well, let me ask you this, follow up to that question. And I struggled with this a lot as a student and going into my clinical rotations, which was, how do I figure out how deep to go in terms of education? Some people want to know nothing. Just tell me what to do. I show up and do it. Some people want to know every single anatomic detail. What do you typically suggest for new graduates or students on how to figure out how much information is good, how much is overload, and how much is not enough?
Yeah, and it is very different. Yeah. I'll get my high school athlete in here who it may be interested in the anatomy and such, or maybe they're interested in, hey, I want to get back to activity. Or I could be treating, maybe I'm treating one of our surgeons post-operatively. Yeah. They probably want a much more detail. They probably already know more. They want more information. And really in that initial conversation, some people say if there's a prehabilitation component, that's a perfect time to have this discussion. Or within that first session, through that initial conversation, you can directly ask them, hey, how much detail do you want about this? If it's too much, let me know. Or sometimes you just get a feel for it. And it's a kind of, there are some soft skills in that regard. But I would, if anything, recommend that you get a feel for that, because if you give them too much information, again, they may check out on you. You don't give them enough, it could be insulted, right? You're not telling me enough here. Sometimes see that on Press Ganey scores. So that is really on you to get a sense and early on just how much information that individual wants, and look for cues of, you're giving me too much, I'm going to check out on you, or I need to know more. Yeah. And again, try to do that early, because then it's going to set that relationship up. It's probably going to be a fairly long relationship during the rehabilitation process.
Yeah. My experience was I just assumed I needed to know the answer. I needed to figure that out. And when further on I went, I realized it's okay for me to ask and say, hey, is this too much information? Is this not enough?
Yeah.
And that actually helped me build sort of therapeutic alliance too. It showed I was worried about them having not enough or too much.
I definitely made the mistake early on of sometimes providing what I would want to know. Right. But I'm very curious, and all of us are, this is what we do. So maybe that's not as much as they want to know. Maybe they don't want to know every detail about the surgery, or why you're doing every single thing that you're doing or that you're recommending. So it's a really, you got to get that read early on and use that to make, basically make that rehabilitation process most effective.
Yeah. And you went with a nice little podcast segue is you talked about pre and before. So how would you describe or how would you explain or educate the role of pre-surgical physical therapy? Why is that so important? Why does that matter? And I think it's popped up or it's gained some notoriety in the last couple of years, this sort of pre-surgical preparation by the physical therapist.
Yeah, it's a hot topic. The term prehab, and it's interesting to see, it makes all the sense in the world that, and we tell people this, hey, the more information you have going in, the more you know about your rehabilitation process, the surgery itself. You hope they're getting some of this from the surgical team as well, and that varies. The easier it's going to be for you, the less stressful it's going to be for you after surgery, and perhaps we're recommending interventions that will set you up, whether it's strength, range of motion, whatever it may be, to do better or recover more quickly after surgery. And we do that with all good intentions. The studies are interesting. The overall trend is, yes, it does. It is a link to outcomes that are better. It gets a little more challenging at times. There's a little more robust information out there for joint replacements, other surgeries. I do hip arthroscopy, lower level of evidence. But part of this is just a challenge of what is prehabilitation or rehabilitation before surgery. What does that entail? It's not consistently defined. It's more education. Is it actual exercise? And what are the outcomes we're looking for? Is it their strength after surgery? Is it their patient-reported outcomes? Just the sense of them telling, I felt more comfortable. So I'm all for it, and we endorse it. And I think overall, all the literature that's available endorses it as well. We have a long way to go to kind of, for as much as we can, standardizing it and knowing really what we need to be really hitting in pre-surgical physical therapy. The only thing I will say is that we have payers that are endorsing it, and
Sure.
they're not going to most of the time if they don't see value in it. So if I think of our joint replacement surgeries, our insurance companies, many of them are covering a somewhat a variably defined pre-surgical episode.
And they wouldn't be doing that, as you mentioned, unless there was some research and some evidence that was actually going to help recovery, and ultimately, right, from their KPI is lower cost, and that's a great thing to do. But if it's helping the human first, that's where we're.
When you can check both boxes, which doesn't always happen, it's always a wonderful thing.
Yeah. All right. So you did mention other resources. Research is always fantastic. But if someone's nodding along and listening to this and saying, okay, I want to learn more about this, are there resources or places that you'd suggest physical therapists to go to maybe dig a little deeper?
Yeah, and it's a great question, and the timing is perfect because I just submitted myself and Dave Korreiser, one of my co-authors, just submitted our manuscript for this. One go-to, because there is literature out. The literature changes somewhat quickly for some of these fields or some of these subdomains of post-operative rehabilitation, and it can be somewhat daunting or intimidating, and you can get some mixed messages. But one resource that the AOPT provides, and right now it is literally in the revision process. It's part of their independent study course series, and that is the Post-Ortho Management Orthopedic Surgeries. Now if you go into the website, I believe it is listed under enrichment only because we're transitioning to they will be publishing a new series. And what they attempt to do is get authors, and often it's a clinical team. So you'll have a physical therapist, a clinician. You may have a mixture of academic representation in there, and more often than not, a surgeon representative co-writing these, providing a summary in a reasonable amount, a one-stop shop, if you will, at the time of the surgery, from what they look at from the surgeon's perspective, the rehabilitation protocols associated with it, gaps in the literature, kind of put together. It's an opportunity for continuing education as well, and many residency programs also use it in their curriculum. I think I would find, and I'm not sure I did write one of the monographs, but I use the monographs that other authors when I get outside of my comfort zone as references as well. And they're great. They're being updated, I think, for early next year, I believe is the target publication date. That's a first stop recommendation I have for anybody at any level.
Talk about that interesting format for a second. I mean, you helped write this, so you got firsthand knowledge. You were paired with a physician colleague. That had to be fun. That's a different way of doing it, is making sure there was collaboration across professions when creating this resource, which is primarily directed at PTs.
Yeah, it is a great opportunity, to really see what they see. Sometimes I don't understand, why they're telling. I'm not always in the office. I'm very rarely in the office when these discussions are being had with patients. And then collaborating with them, I can see it. I can see this is what you do in surgery. These are the concerns. We know what they're doing, but we don't know everything that goes on around that.
Sure.
And at times, getting a even just a glimmer of what they are looking at in their clinical decision making and why they make recommendations, and then also it evolves into good discussion. You get to share points of view, and sometimes maybe they will change what they're doing based on what you're saying. That has definitely happened, and vice versa. And it's just great to get that perspective. And it's often depending where you're practicing, you may not get that opportunity very often.
Right. And you get to take advantage, sort of highlighting the format for this independent study course. You get to take advantage of that collaboration. A lot of times they say, the biggest problem with communication is when we think it has occurred. So Why are they doing that? They don't understand me. It's like that when this comes together, we're closer to achieving more understanding. And I think that's one of the main benefits of an independent study course like this is that it wasn't written just by a physical therapist. It had cross-professional collaboration.
And the editors were very, particularly specifically in the upcoming edition, they said, can you include what physicians sometimes think about when they think about why is the physical therapist doing this? I'm thinking this, but why are they thinking this way? And it kind of, they're not always clashing points. Sometimes you're thinking alike, you're just communicating it in a different way.
Right.
And there's some great kind of interaction there. And I think clinicians, physicians and PTs would find it useful to look at that and kind of get a sense of the viewpoints and why sometimes we see these recommendations or these points of conversation that we often have during the rehabilitation process.
Yeah, the more we know, going back to that series on TV. All right, we're going to put you on the spot, Keelan. We have a segment on the show called Words of Wisdom. Wow. What would you want to leave with the audience about this topic? Is there a parting piece of advice or wisdom?
Yeah, what I would tell anybody, wherever you are, and I feel like this is what I tell myself every day when I do this, is that you really have to expect that change is going to occur. Whatever is here today is going to change tomorrow, if not tomorrow, next week, next month, or next year. Every time that I've had this great monograph we put out, one, it gets knocked down by the editorial process. So, we said the clinical practice guidelines too. You look at it like, these are great recommendations. Like, that's a C-level recommendation. That's actually better than we had. It was an F in 2014. Now it's a C. Maybe someday we'll get to an A. But what you have to realize the evolving nature of this. And it's always going to change. Surgeries always change. Our rehabilitation associated with those surgeries, it's going to be an ongoing change. So you should be satisfied when you see that, if we want to call it improvement, or that evolving process, but just know it's going to evolve into something different, hopefully better tomorrow, or if not tomorrow, soon.
Yeah, I was taught in PT school, just add one word onto the end of what you're sharing. This is what I understand to be true now. That word right now says, so we understand now, and that leaves you sort of off the hook if and when information changes.
It's your disclaimer.
It is my lifelong disclaimer. So that's fantastic. Keelan, thanks for putting the time and the effort and the research into that independent study course that you mentioned, coming out very soon from AOPT, available at orthopt.org. And thanks for taking the time to talk with us today on Orthostatic.
Thank you. Thank you for having me. I appreciate it.